both ways. This 70-year-old gentleman from Vellore presented with feeling of choking sensation associated with the change in voice for 2 days. He was recently admitted and discharged here for acute gastroenteritis due to stool culture grown group D non-salmonella typhi. After discharge, he had multiple episodes of choking sensation associated with the voice change. It was intermittent and resolved spontaneously. And there is no difficulty in swallowing, no chest pain, palpitation, no other complaints. Increased frequency of symptom even at night with disturbed sleep. So he came to ED. He's a known diabetic with micro and macrovascular complications and a known hypertensive, not a smoker, occasional alcoholic. On examination, he was conscious oriented, no other general examination finding. Vitals are stable. He is maintaining saturation at room air even of the episode. Even during the episode, JVP was not elevated. Other system examination was unremarkable. CNS examination, he had an intermittent dysphonia present during the episode, and he had an abnormal movement of tongue and abnormal posturing of thumbs. And he had a neuropathy due to features due to diabetes. This is a he had an involuntary movement of the tongue. Intermittently, it will come and resolve spontaneously.
That is when asked to protrude his tongue.
Summarized, 70-year-old diabetic hypertensive. He presented with choking sensation for 2 days with abnormal posturing of upper limb, tongue, and intermittent dysphonia. What are the differentials?
We have a slide.
Initially, we consider differentials of MI due to this thing and bronchospasm, esophageal spasm, GRD, and acute laryngeal dystonia. And investigation-wise, ECG was normal, CKMB dropT was within normal limit, electrolytes are within normal limits, and other investigations are also normal. ENT evaluation was done immediately, and the NPL scopy was done, which was also normal. Swallowing was normal. Then he recently discharged with ciprofloxacin, treated with the cipro, metro, and pantoprazole and domperidone. We have done a drug review. We have made a final diagnosis of acute laryngeal dystonia, drug induced, with the diabetes and hypertension. We found out that due to domperidone, because we match clinically, we match with Naggero algorithm also fit with probable ADR. Domperidone is usually a peripheral dopamine 2 receptor antagonist. Usually, it will not cross blood-brain barrier. It will usually cause in pediatric age group and EPS extrapyramidal symptom in either pediatric age group or elderly, because in pediatric age group there is underdeveloped blood-brain barrier, and in elderly age group the permeability will be due to altered protein expression. This is on a case report. There are few case report that shows that domperidone causing acute dystonia. This is one case report that caused a domperidone associated acute dystonia and due to consumption of domperidone with pantoprazole. It's the same thing like that. They had all investigation was normal. They found out due to secondary to domperidone, and they started with tetrabenazine and the symptoms improved. This is another case report in BMG. The same thing. Domperidone and promethazine, after promethazine his condition improved. This is a case review of acute laryngeal dystonia. Usually, sometimes it will cause a severe respiratory failure. Most commonly, it will occur secondary to antipsychotic agents. It will be life-threatening. we have to find it immediately. We have to properly view the drug. Otherwise, it will lead to laryngospasm and respiratory compromise. Usually, management will be anticholinergics or antihistamines. This is a common drugs causing EPS, mainly dopamine receptor blocking agents. Most commonly is a first generation antipsychotics. It will cause second generation, little less from first generation, but it will also cause EPS symptoms like olanzapine, risperidone, flupenazine, aripiprazole. And the most common antiemetic which cause will be metoclopramide because it will cross the blood-brain barriers. Domperidone rarely will cause like this, and prochlorperazine. And other drugs which cause extrapyramidal symptoms, SSRIs, antidepressants like amitriptyline, anticonvulsants, and mood stabilizers and calcium channel blockers. Usually, acute dystonia occurs due to imbalance between anticholinergic and the dopaminic effect in a nigrostriatal pathway. Acetylcholine has an inhibitory effect on movement, and dopamine has an excitatory effect. There is usually dopamine receptor blocker will cause inhibited direct pathway, and that will lead to activation of indirect pathway in basal ganglia that lead to delayed and uncoordinated movement and dystonia. Common treatment option for dystonia is IV anticholinergic like diphenhydramine, benzatropine, oral anticholinergic like trihexyphenidyl, and we used antihistaminic with the anticholinergic property phenylalanine, promethazine, diphenhydramine, and other GABA receptor agonists like baclofen. Rarely we can use botulinum toxin or surgical if it is severe and it will not subside with medications. We found out it's due to domperidone, and immediately we have given a phenylalanine, promethazine, and after that its symptom immediately got settled. The learning point from this presentation is domperidone is one of the common drug we use, but it will also cause dystonia, very rare complication, 1 in 10,000. We have to know about the complication of each area of each drug, and yearly diagnosis, usually it will be life-saving. Otherwise, this man will lead to laryngospasm and lead to respiratory compromise. So it will prevent also unnecessary investigation and improve diagnosis. And in geriatric population, we have to review the drugs because sometimes drugs will cause a effect like pediatric population. Geriatrics also we can prescribe each medication with cap.
Sure. Interesting case, good presentation. Just one feedback. See, at MD level, you should be able to differentiate from history and examination whether it's a UMN syndrome or LMN syndrome. Relevant history for that has to come. And when you put the differentials, you have a clear-cut neurological syndrome here. So put in the order of likelihood. Otherwise, very interesting case. Thank you. Next one. Yes. Sir.
Yeah, actually, I haven't seen too many dystonic reactions with antipsychotics, traditional or atypical antipsychotics. We very well know that they cause EPS and akathisia, but I haven't seen too many acute dystonic reactions with them. Maybe psychiatry does. The most well-known drug is metoclopramide, which is not hardly used nowadays, but they used to come with these striking oculogyric crisis and usually severe dystonia of the neck. They're looking like that. This one was more subtle than that, you know. He kept saying he's choking. He looked pretty normal, but one interesting thing he noticed when he was keeping his hands like this, his thumbs were hyperextended like this. And when he put out his tongue, he was doing this, just moving it around, and he was not aware of it. So it's this one was kind of subtle. It was more laryngeal. Anyway, an interesting case.
Will you like neuromandibular dystonia, like tongue
Yes.
and nose?
Yeah, it was mainly that tongue. Putting it out, he was just after some time he started moving it around, putting it in and out.